The clinician has the information in front of them already, whereas prior to the digitisation of the questionnaire, there was a lot of time spent face-to-face with the patient, phoning specialists, chasing results, organising tests. And so already, just by implementing the digitisation of the questionnaire, we've seen improvement in these measures.
I think one important number to also mention is screening patients has gotten a lot easier. So we have a physiotherapist who screens patients remotely, and in the time it used to take them to screen one patient, they could actually screen 24 now.
I'm Andrew Marks. I am a clinician, a staff specialist anaesthetist here at Royal North Shore Hospital in Sydney, Australia, where I also hold the Director of Perioperative Medicine. I am a researcher with the George Institute, and I have a special interest in perioperative medicine.
Hi, I'm Kanika Chaudhri. I am an Anaesthetic Senior Resident Medical Officer at Royal North Shore Hospital, Sydney, Australia. I'm a Research Fellow at the George Institute, and my research interests are within anaesthetics, but developing.
The background to the Diamonds project was a clinical redesign project done here at Royal North Shore Hospital called the Impact Project, which was focused on improving the efficiencies associated with our pre-admission clinic for patients coming through for elective surgery. That's a year-long clinical immersion project, after which we took over, in particular looking at the arms of a digital perioperative pathway, as well as redesign of the clinic space itself. Our hypothesis for the Diamonds project is that we know that when patients prepare for their surgeries and present for their surgeries in a stronger, more optimised state, that we can reduce the number of post-operative poor outcomes, be they complications, increased length of stay, things of that nature. But what we had identified through that initial project was that it was very frequent in our institution that we would only be able to have a clinical look at these patients in the days to a week prior to their operation, despite the fact that they might have been sitting on the surgical wait list for months. By digitising the patient health questionnaire that is given to the patient at the time that they are waitlisted for surgery, we can now front load the information our clinicians require so that they were able to risk stratify our patients and put them on perioperative pathways, as well as identify areas where we could optimise our patients, or in some cases offer prehabilitation, so that when it did come time for their surgery, they had used those months to get themselves in a better position for that surgery, rather than just waiting around and either having to be cancelled on the day of their surgery or postponed so that they could have the requisite investigations or treatment. When we think of optimisation, it's in many ways an umbrella term which has the two main categories of patient comorbidities, which can be optimised for the stress response that gets induced as part of having major surgery, as well as the term prehabilitation, which is a muddy term in the literature in the sense that a lot of the studies call their intervention prehabilitation and have different elements. But at its core, prehabilitation looks at the physical, the nutritional, and the psychological aspects of preparation for an intervention, in this case surgery, and trying to improve muscle mass and tone, improve protein in particular intake, and improve patient readiness for their surgery. And there is now emerging evidence that this bundle of care is is beneficial for patients when they do come in for these bigger operations. So what we're looking to do when we talk about optimisation is identify the patients who are going to benefit the most from these prehabilitation bundles of care, as well as to identify the specific comorbidities that patients may have, such as heart disease, diabetes, anemia, and work out if there is something that we can do for the comorbidity now, prior to surgery happening, so that when the patient does have their surgery, it's not going to be another factor in a post-operative complication.
The intervention itself is digitisation. Once the patient is recommended for surgery, we use a digital platform to send them an invitation. This invitation, once accepted, sends them an extended health questionnaire. So the questionnaire that was originally done on paper is now sent online. Once a patient fills out the questionnaire, it flags for us the patients who are high risk. So those patients that Andrew mentioned automatically get flagged to us, which is impossible to identify through paper. The next step, I guess, is the automated resources that are already sent to them, that are getting sent to the 100% of patients that are being flagged, and also reviewing those high-risk patients. Diamond's Methods has 4 overarching projects. The first is looking at a retrospective analysis, so doing a pre-post analysis of implementation and seeing whether implementation has changes in those outcomes. Whether it be length of stay, readmission rates, whether it be duration of pre-admission clinic. Secondly, we're looking at an economic evaluation. So has there been a cost saving from what we've done from digitisation? Looking at a process evaluation, so whether or not the study works and whether or not the patients and the staff have seen an improvement in their workflows and what their thoughts are, really getting into the depths of what their thoughts are. And lastly, doing a think tank style study, looking at a workshop and seeing the outcomes and really having those key users in a room and doing a focus group.
To add what to Kanika has been saying, the main issue that we had with the paper-based pathway and the real reason that we saw the need for the digitisation of the questionnaire was it was not uncommon for us to have patients in category B or category C where they would have waiting list times of 6 months to a year or beyond. And they would submit their paper questionnaire, which would be stamped. They'd be assessed as whether they needed to come to pre-admission clinic or not. But then the paper file would be placed in a filing cabinet and literally 4 to 6 months later be pulled out as that patient's name got to the top of the list. We would then see the patient clinically in the pre-admission clinic about a week prior, if we were lucky, to their scheduled surgery date. And it would be at this time we would identify issues that either meant the patient was going to be at increased risk as a result of proceeding with their surgery, or we'd actually have to put our foot down and say this patient is not fit for surgery and compound the delays to them getting their operative time. So the real benefit that we found by bringing in the digitisation of that questionnaire was we could now front load this information clinically so that we could identify and flag the patients where we might need them to see another specialist, get another investigation, or actually start a course of treatment before that they were safe to proceed with their operation.
The duration of the study was 6 months. We looked from June to December in 24, and in that we invited 3,300 patients onto the digitisation. 90% of these actually completed all their forms, and a majority of these users who gave us feedback found the platform easy or very easy to use. Clinically, we've had some great outcomes as well, which I guess you can talk through, Andrew.
Certainly. I think what we've noticed already is that by having better prepared patients, but also better prepared clinical staff with visibility of these patients, we've already noticed a decrease in the number of patients who require face-to-face pre-admission clinic appointments, dropping more than 20%. And we've also noticed that when the patients do need to come to pre-admission clinic, the duration of their pre-admission clinic has almost halved. And that's basically down to the fact that the clinician has the information in front of them already, whereas prior to the digitisation of the questionnaire, there was a lot of time spent face-to-face with the patient, phoning specialists, chasing results, organising tests. And so already, just by implementing the digitisation of the questionnaire, we've seen improvement in these measures.
I think one important number to also mention is screening patients has gotten a lot easier. So we have a physiotherapist who screens patients remotely, and in the time it used to take them to screen one patient, they could actually screen 24 now. The study's being led by Northern Sydney Local Health District, and we have two main key collaborators, which is Australian Institute of Health Innovation and the George Institute for Global Health, and both of them have been helping us out and partnering with us. Funding wise, I guess I wasn't really there for the seed funding. When did the funding start?
So initially we got seed funding from interested clinicians, the staff specialist anaesthetist group and the wider staff specialist trust at Royal North Shore Hospital, along with the Northern Sydney Anaesthetic Research Institute, provided the funding for the first year's licence trial of the platform technology. And since then, with some early results, we've been able to, through winning of the Northern Sydney Local Health District Innovation Pitch Program and through the North Shore Campus research grants, receive further funding to allow us to conduct the research as well as maintain the platform licenses. Locally, we've noticed an impact already in our staff workflows in the perioperative environment. We're changing the way that we process patients coming in for elective surgery now that we have this information so early. It's about adapting to this new circumstance and being able to use that. And definitely as we start looking forward towards optimisation pieces and fleshing out those optimisation streams, we would expect then to start noticing patient outcome differences. We've also had a broader impact with acknowledgement from the AHHA, the Australian Hospital Health Association, where we did a webinar with them to great interest from around the country. Definitely it seems there are lots of people looking in this space, and we are able to provide some of that early information in terms of what has been successful and where potentially there are challenging points in implementing a digital platform. And we've also had institutions from across the country reach out to us as they look to implement something similar, and we've been able to aid them from that impact as well. I think one of the big impacts that we have had are actually been for our patients. Now when a patient comes for a subsequent procedure, they don't need to refill out the same paper form, but they have pre-saved answers that they just need to review on their digital platform. The patients that are no longer required to come face-to-face for their pre-admission clinic, that is a time saving as well as in the environmental cost of trying to get to the hospital. So those impacts are starting to be realised as well.
Some other things that are going on in this space are the publications that are coming out of it. So those 4 key publications that we're looking at publishing, but also the local impact that we're having here. Right now, this platform is live in one hospital, which is Royal North Shore Hospital, and we are looking at seeing where we can expand within Northern Sydney Local Health District itself. And there is the potential for optimizations of those patients that we earlier identified as high risk, whether or not we can see it provide them with proper prehabilitation and optimization now that we can easily identify them.